Okay, good morning, everybody. Good morning from the UK. My name is Professor Paul Tipton. I am President of the British Academy of Restorative Dentistry and also Director of Tipton Training Limited. So today we are going to discuss the difficult proposition of tooth preparation. Now, make no bones about it, tooth preparation is not easy. And it's not easy because we've not been taught at university, and there are not that many courses outside university that teach you a specific protocol for tooth preparation. It's a big topic, so we've broken down tooth preparation into various stages. Today we're going to talk about the essentials of tooth preparation. We have other webinars that talk about the 4 elements of tooth preparation. Other webinars that are talking specifically about margins, axial inclinations, how we prepare resistance retention form, etc. So this is part of a whole series. So let's look at the basic essentials of tooth preparation. Okay, so our first involvement in this should be to do some background reading. And we've got 2 excellent books out there which you need to go and have a read of to get a full fundamental idea of how tooth preparation should go. And these are both by Schillingberg, and they're called Fundamentals of Fixed Prosthodontics, which is a great book if you want to learn about fixed prosthodontics. Tooth preparation is obviously a big part of that. And the other one is the Fundamentals of Tooth Preparation. Now, I'd advise you to get that book because every single type of tooth preparation you'll ever want to do will be inside that book. So you can look through the pages and you can basically get a diagram by diagram view of how you do it. Of course, there's nothing that can beat actually preparing hands-on. So hands-on courses are obviously the step after the theory. So we're going to break down our webinar this morning into these steps. And what I'm talking about in the essentials of tooth preparation is preparing to prepare. So I'm not going to actually talk too much about the individual tooth preparations. This is you getting yourself organized so that then you can go and do a very good tooth preparation. So first question I'm going to ask you is, why is it important to be a good tooth prepper? Okay, and I can answer that several parts. Number 1 is that we know our dental technician needs a certain amount of space. So being a good prepper means giving him the correct amount of space, enough space for him to go and do a good aesthetic, long-lasting, functional restoration. Number 2, however, we do not want to over-prepare. If we over-prepare, then the possibilities are pulpal exposure or damage to the tooth. So we have a very, very fine line where under-preparing means that we're not going to get the good-looking, long-lasting restoration that we want. Over-preparing means that we're going to damage the tooth. This is why tooth preparation is so difficult. We have to do the exact amount so that we can get it right. Next reason is that we will be judged, whether we like it or not, we'll be judged by our partners in restorative dentistry, in fixed prosthodontics in any case, are our dental technicians. And of course, they're probably the only people that are ever going to see our work. And we'll be judged by them. We'll be judged by them on how good our tooth preparations are, how good our margins are, how good our impressions are. Now, we all know that to be a good dentist involves more than just prepping teeth. It involves using the brain, treatment planning, etc., etc. But our technicians do not see that part. They see the preparation that comes to them. And guess what? Technicians talk to each other. Technicians talk to other dentists. Okay? And you want to be the one that they talk about when your name crops up and they say, oh, that's right, Dr. Such and Such, great pair of hands. Okay? He or she's fabulous. Preps the tooth really well, great impressions. And guess what? That will stay with you. People will judge how good a dentist you are very often on how good you can prepare teeth. So it's very important for number one, the end result, and number two, your reputation going forwards. And if you can be the good prepper, you will get further, quicker in this profession than other people. So we're going to start off with tooth anatomy. And we need to understand tooth anatomy. So let's just look at a central incisor. Imagine now that I'm going to do a porcelain veneer preparation on the upper right central incisor. Okay, I'm just going to discuss the margin for now. So question to you again is, how much tooth tissue do you take away at the margin for a labial preparation for a porcelain veneer, ceramic veneer? Okay, number one, should be a chamfer preparation. You should know that. So what we need in terms of depth of preparation, okay, we need two things. Number one, we need space for our dental technician, we already mentioned that, to do his work. So have you ever asked your dental technician how much space he needs at the gingival margin for him to do a good looking restoration? Okay. It used to be maybe before the time when feldspathic porcelain moved to milled restorations, it used to be maybe 0.5 of a millimeter. However, now life has changed. Technicians have got better at the job. We've got better materials. We've got better techniques. And now we can get the ceramic restoration, especially a milled one, EMAT, something like that, down to 0.1 of a millimeter. Now, be aware, not every technician can work to 0.1. So we have to understand what their minimal requirements are. Okay, so ask the question first of all. So that's the first thing. How much space is required? The second part is, if we want longevity, okay, for our restoration, we need to bond to enamel. So if I'm going to bond my veneer to the upper right central incisor, then the most important part that I'm going to want to bond to enamel is the periphery, the margin, so it doesn't leak. And we know from many, many studies that if we bond to enamel, we've got something like a 92–93% success rate over a 15-year period. Now that's a fabulous success rate when it comes to porcelain veneers. So we have to bond to enamel. So this brings us to the question now of the anatomy of the tooth. So how much enamel is there just supragingivally, where that arrow is pointing, on the average central incisor? We have to work with averages, okay? But if you don't know the average, you can't go up or down a little bit. So we go to our textbook, we go to our scientific papers, and it shows us that on average, 0.36 of a millimeter. So on average, if we cut a 0.4 or 0.5 millimeter preparation, then we will be in dentine at or very close to the margin, which is not a good idea. So on average, we have to do a preparation which is less than 0.36, so we can try and stay in enamel. So our maximum, okay, this is our maximum preparation at the gingival margin for a central incisor is therefore 0.3. We'll look at what sort of burr and how we're going to cut 0.3 in a minute. And that's another difficult thing, is actually how do you cut the right amount off the tooth? We'll look at that. But number one, let's just deal with the theory of how much we should be cutting off. Now, if that 0.3 is your maximum, when might you do more or when might you do less? Well, certainly I'm not going to do more. 0.3 is going to be my maximum. What about less? Okay, when might we see patients who have less enamel at that gingival fur, that gingival margin? Okay, well, smaller tooth, less enamel. So if we see smaller teeth, we'll naturally bring that back. So maybe 0.25, 0.2 of a margin. Okay, when else? Older patients, someone like me, been around 60 years, scrubbing their teeth. And the more you scrub your teeth, the older the patient, the more you're going to wear the enamel. So as we're treating older patients, we do less prep than younger patients. Third thing we need to look at, is there any erosion going on in the mouth? Not just necessarily on that tooth, because if it's happening on premolars, for instance, then that's happening all around the mouth, whether you like it or not. You may not be able to see it on a central, but it is happening, and that enamel is thinning. So in some situations like that, we'll go down to 0.2, maybe even 0.1. In some situations, no preparation whatsoever. Okay, and you've heard of non-preparation veneers or prepless veneers. Well, we can do in certain situations a non-prep veneer. So margin thickness, hugely important, but you need to know the anatomy. The anatomy tells you what your margin should be. Okay, what about a lateral incisor? More or less enamel there. Okay, well, you're going to see here straight away, lateral incisor. Funnily enough, you wouldn't expect it, but there's more enamel there. So we come back a little bit from 0.39, and our maximum preparation now becomes 0.35. Okay, same parameters. That can go down, it won't go any more, but it can go down if we've got an older patient, a smaller tooth, and we see any erosion taking place. Okay, let's move on to the canine. Let's have another guess at the canine. More enamel or less enamel? Well, part of you says it's a bigger tooth, therefore it's bound to have more enamel. However, what color is the canine? The canine's usually a much darker color, isn't it? And why is it a darker color? Because there's less enamel and there's more dentine. So we now go and we see on the canine, on average, 0.29. So my maximum preparation is 0.25. Again, we're going to talk in just a second how we actually cut that. We also need to look at crown work, okay? And this is why anatomy is so important everywhere around the tooth, okay? So a question to you. You have a proclined upper central incisor. Patient is not going to have any orthodontics done, says no to orthodontics, says yes to a crown. So you're going to go and do a ceramic, dentine bonded crown. How much can you move the mid-labial surface of that proclined central incisor? How much can you move it backwards without going into the pulp and potentially devitalizing the pulp? Okay. For that, you need to know how much thickness of enamel and dentine is there, at least the average. Okay, so at least the average. And as we know, the average amount is 2.55 in that area. Lateral incisor, much less, 2.15. On a canine, much more, 2.95. And therefore, if we think about that, I can do a preparation which is, let's say, 2.5, 2.4 millimeters deep. And I've not gone into the pulp. It's a heavy preparation, but I've not gone into the pulp as yet. I'm not exposed. And I can now put a restoration back, which is maybe 0.4, 0.45 of a millimeter, nearly 0.5. And what I've done is I've taken that labial surface back by 2 millimeters. How much can I take back the labial surface of a lateral? About 1.5, 1.6 millimeters. What about for a canine? I can take a canine back around about 2.4 millimeters. Now, this is important not only for you when you're prepping teeth, it's also hugely important when you're doing smile design, smile makeovers, and of course your lab technician. It's no good a tooth being proclined like this and the lab technician taking it back 3.5 millimeters mid-labially, because then you're going to be in the pulp. So your dental technician also needs to understand how much he can take back that mid-labial surface. Similarly, when we're talking about midlines, okay, it's important that you know how much tooth tissue there is on the distal aspect of a central incisor and on the mesial aspect. So if you're going to be preparing mesially and distally, you've got roughly 2.4 millimeters on the distal aspect, 2.3 millimeters on the mesial aspect. So when it comes to moving center lines, again, roughly you can move a center line about 1.9 to 2 millimeters of a central incisor. So tooth anatomy is so important. You need to understand it. Now, going hand in hand with that is correct burr sizes, okay? And a simple question to you, the burr you pick up to do a preparation with, do you know its size? And in terms of size, we're talking about two things. We're talking about thickness of the cutting tip, and we're also talking about inclination, because we need to cut margins of a certain size, and we also need to cut inclinations. So the first thing you should be doing is, in the textbooks, It will show you how much depth of preparation there should be. We've already discussed a porcelain veneer. We don't have time during this webinar to go through every single restoration, okay? But you need to understand the thickness of the burrs. Now, basic burrs. We have two basic types of burr that we will use for margins especially. Shoulder burrs, chamfer burrs, okay? Now realize, with a shoulder burr, you cut with the whole burr. So as I'm starting to prepare a tooth, my shoulder burr is on the tooth, and I know that I've cut the right amount off when the edge of the burr is flush with the margin. So with a shoulder burr, if I want to cut a 1 millimeter margin, I use a 1 millimeter thick shoulder burr, and I keep on preparing until the shoulder of my burr and margin are flush with each other. Simple. However, when we're dealing with a chamfer, the chamfer's completely different. Okay, with the chamfer burr, we need to cut with only half. So once I know what my thickness of preparation should be, so let's just say I'm going to do a 0.3 millimeter chamfer on a central incisor, I have to go and pick a 0.6 millimeter chamfer burr. That means the cutting tip is twice the size of the actual margin that I use. So the only way that I can now tell that I've cut exactly the right amount of is when I look from the side, I'll see my chamfer burr is half on and half off the tooth. This is why it's so important that if we want to cut with precision, which is what our patients expect of us and what we should be doing, if we want to cut with precision, we have to know the size of our instruments. So guys, please go and get yourself a set of digital calipers, okay? £15, £20 set of digital calipers, and we now go and measure the tips of our burrs, okay? The cutting tips of our burrs, and we understand which burr that we should use for which particular job. Now, imagine I'm going to cut a central, lateral, and canine gingival margin. Central, maximum 0.3, therefore it's a 0.6 burr. Lateral, maximum 0.35, therefore it's a 0.7 burr. Canine, maximum 0.25, therefore it's a 0.5 millimeter thick burr. Guess what? All those three burrs look, when you look at them in a burr block, they look exactly the same. Okay, so it's one thing is measuring them. The second thing is now identifying them. Okay, and we need to put some form of index in there. So what I do, that's what I suggest you do as well. And remember, this is preparing to prepare. This whole webinar is about you getting yourself organized. Remember, we're in COVID-19, we've been in lockdown. This is something that all of you should have been doing. If not, do it now. Measure your burrs, identify them, and then label them. The best way to label them is to get a little bit of nail polish. Okay, there's so many different colors of nail polish out there. And where the diamond burr, okay, here, let's just go on, let's just go on a couple. Okay, where the diamond burr here, you can see we've got already a blue line. Where the diamond burr part and the shank meet, just around that area there, or over the blue line, go and paint a little bit of nail varnish. So it may be that 0.6 millimeter burr, we have a red line around there. The 0.7, we have a pink line. The 0.5, we have a white line. It's easy to identify. And as soon as you get into the swing of this, you can do a little index for yourself to start off with. Stick it on the wall, stick it in your, somewhere in your surgery. You can pick it up and have a look at it. You're now picking up the right instruments at the right time. Now, next thing. We've talked about margins and what our margins should be and how we identify them. The next thing is we need to talk about inclination. So various tooth preparations, and we can go from Gold, PFM, Zirconia, Emax, okay? They have different amounts of axial inclination convergence angle, okay? Now understand that. They all have different amounts. So if we're using a metal-based restoration, such as a PFM or a Gold, okay, then we will have a different axial inclination to Zirconia or to Emax. So traditionally, our convergence angle is for a PFM or Gold 12 degrees. Okay, think about this now. Start thinking, how am I going to cut exactly 12 degrees? What does 12 degrees look like? Convergence angle for zirconia around about 15 degrees. Convergence angle for Emax around about the 20-degree mark. Now, why is there a difference between the three? Okay, let's talk you through this, just so we can understand. The first thing is, what cement do we use to put on PFM, to put on zirconia, to put on Emax? Okay, I would suggest to you that most PFMs and gold should be cemented with traditional zinc phosphate cement. Okay, why? Two reasons. Number one, it's the thinnest film thickness. Number two, it gives you great working time. I can put on 6 crowns, cement 6 crowns on with 1 mix of zinc phosphate. And it's the thinnest film thickness, which means to you what? You get better seating, because the flow of the zinc phosphate, because it's the thinnest, it will flow out better. You'll get better seating. Now, what happens when we go to zirconia? What's our recommended? So recommended zirconia, at the back of the mouth, I'll still go with zinc phosphate. At the front of the mouth, I'll go with a resin modified GIC. Now, what's the thickness of the resin modified GIC? It's thicker. And therefore, how am I now going to get that zirconia crown with a thicker cement loop to seat down? Only way I can do that is to start to alter the convergence angle so that the cement can flow out more easily. Third one, look at Emax. Okay, what do you cement Emax on with? Usually it's a resin cement, it's a composite luting cement, a flowable style of composite. Again, thicker film thickness yet again than resin modified GIC. And therefore we have to again increase the convergence angle. Now the second part of this story is how much pressure we put on when we cement the restoration in place. Okay, for a zinc phosphate cemented PFM or gold, we use a lot of pressure. We can really hammer that crown down into position. Now, what happens if we do exactly the same thing with zirconia? There is a chance that we might get chipping. So we can't use the same pressure to cement zirconia as we can PFM. Therefore, how do we get the cement to come out? By changing the convergence angle. And finally, with Emax again, how do we get Emax cemented down? We can't put very much pressure on it at all. We can put thumb pressure. We can maybe tap with our nail, but we can't put too much pressure because again, it may fracture, especially when we're doing something thin like a porcelain veneer, where it's 0.1 or 0.2 of a millimeter at the margin. That can fracture if you put too much pressure on. Therefore, we need more convergence. So your convergence angle is dependent upon 3 things. Margin, not talked about that. Okay, that's another time. Cement that you're going to be using and the type of restoration, which will give you how much force you put that restoration in with. Therefore, let's now start to talk about how do we cut with that sort of inclination. So the first thing, obvious. Now think about this as not being a dentist. Think about this as being an engineer. We are doing micro-engineering in the mouth. Okay, so you are a micro-engineer in the mouth. You want to cut with precision. How do you understand the inclinations? You go to this, guys. Okay, you go to a protractor. You use one at school. Buy one now. Use one. Start to understand what angles look like. You're cutting angles all the time. It is logical. It makes sense. It is part of our preparing to prepare. Become a better prepper by understanding preparing to prepare. Get yourself a protractor. And now we start to look at angles. We can start to put a burr in here and we can start to look at the different angles. So let's just go and look at this particular burr that we've got on the right-hand screen. Big burr, I know, but look at the inclination of it. So that inclination is 6 degrees. That convergence angle is 6 degrees. So what does that tell you? That tells you that if you use the burr vertically all the time and go around the tooth vertically, you will cut a 3-degree inclination one side, a 3-degree inclination the other side. Sorry, that's not good enough. Okay, we need twice as much as that for a PFM, more for zirconia and Emax. Okay, so what are we going to do? We've got a burr that's got a 6-degree convergence angle. So what we do now, something completely different, is rather than using the burr vertically, we use one side of the burr vertically. So we angle the burr slightly, so one side of it is vertical. And now we're cutting with a 6-degree inclination. So understand the geometry of all this, that if you get a 6-degree convergence angle burr, okay, most of them you're going to find are like this, okay, but your protractor will tell you. You can now go and cut an exact 12-degree convergence angle if you don't use the burr vertically, but you put one side wall so it's vertical and then cut. So I'll put one side wall. Let's do the mesial aspect. I'll cut the mesial with my side wall of the burr vertical. So the other side, not like this, like this. The other side is now cutting at 6 degrees. I'll do that on the distal. I've now got my 12-degree convergence. What does 12 degrees, what does 6 degrees actually look like? Okay, we need your protractor. The other thing which will be of help to you, okay, and many people poo-poo this, they say, oh, that's ridiculous. Get yourself a clock, a big clock. Put a big clock on the wall facing you. So I'm preparing my patient here now. I'm looking in front of me. I have a big clock, okay? The big clock is not a digital clock. It's a traditional clock with big hand and little hand, and it goes around, okay? On that clock, we can see, we can work out angles. Okay, what is 6 degrees on the clock? 1 minute past 12. So big hand at 12 o'clock, little hand 1 minute past 12, that is 6 degrees. Visualize it. You have to be able to visualize what these things are. Otherwise, you'll never be able to cut them. Okay, so if we want 6-degree inclination, we look and we can see that's the inclination that I want to be cutting to the vertical. If I want to look at 12 degrees convergence, then the big hand is at 1 minute to 12. The little hand is at 1 minute past 12. You can take the batteries out, okay, and move the hands around. Now you can look and you can say 1 minute to 12, 1 minute past 12. There is my 12 degrees convergence. Look at my prep, look at the clock. Look at my prep, look at the clock. This is cutting with precision. Understanding the instruments that you're going to be using and work with them in a certain way, as therefore you will cut exactly the right amount. And again, as we mentioned, we need to understand whereabouts or how we use these burrs. As you can see here, this is a chamfer burr, and I'm cutting at the moment a 1 millimeter margin, chamfer margin on here, and I'm using a 2 millimeter wide burr. Now this burr has got inclination, it's a tapered burr, we just talked about that. Therefore, the cutting tip and the base of the burr here are at different angles because we are tapered. So question is, when you're looking at a cutting tip, whereabouts do we measure? Because guess what? The width is getting less and less and less as we go down the burr. So we need to understand where to measure, okay? So if I want to cut a 1 millimeter chamfer, I need a 2 millimeter burr, yeah? I want to cut a 0.5 millimeter chamfer, I want a 1 millimeter burr. Where do I cut? Okay, I cut where the flat part of the burr stops and the round part starts, okay? And you can see that's just about there. Again, on the other side, flat, 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 starts to curve around there. Now for this, you also need to get your loops on so you can see. So again, we have our loops, we have our burr supply, we go and measure, we then put some nail varnish on, and that's our index. So we now know that that's a 1 millimeter cutting margin burr, okay? So we know our anatomy and we know our correct burr sizes, and that's going to influence how you go about these things. The next thing is two-handed tooth preparation, okay? So most of you, again, taught at university that if this is my turbine, I'm going to hold the turbine like a pencil and I'm going to prepare. And I might get a finger grip okay? And I'm going to prepare around the tooth. Now, as I'm preparing around the tooth with this burr, look what's happening to my wrist. My wrist is going at different angles. And one of the difficult things for people with tooth preparation is making sure that the wrist stays at the right angle. So once you've got the right angle to prepare at, then make sure that your wrist does not go off that angle. If it does, then you're preparing either undercuts or too much taper. So how do we do that? We lock our wrist. So guys, how do most people lock their wrist? They lock their wrist by squeezing harder on the turbine. Pick yourself a pencil up and just use this analogy. Okay, pick up the pencil and now hold it or try and lock your wrist. As you're locking your wrist, all you're doing is squeezing hard on the pencil. The only way we can lock our wrist is by pressing against something. Okay, so now we press against something. So I put another finger on. I'm now using two-handed preparation, and that automatically locks the muscles in your wrist. So two-handed preparations for two reasons. Number one, two hands are better than one. Look at tennis players. Okay, they use two hands on the racket. We have more control if we use two hands than we have one hand. That's number one. Number two, it locks the wrist and it stops that burr going off axis. We need to be able to cut with exactly, we've already mentioned it, exactly the right inclination in the right area. And therefore for that, we get ourselves orientated, we get the burr in the right position, we therefore lock our wrist. If you're doing one-handed, as you're preparing, then your wrist will get unlocked and your burr will go off that correct inclination. Now, we cannot do two-handed tooth preparation everywhere, obviously, because the palatal access, the palatal surface, I can't get visual access to. So we're talking about two-handed preparation when we've got direct vision. So labial aspect, I can do two-handed preparation on the labial. I want to do the mesial now. I turn my patient's head to one side and I can cut through mesially. I want to do the distal, turn the patient's head to the other side, I can cut through the distal. So now I've done for a central incisor 3 surfaces with direct vision. I'm now going to do the 4th surface with a mirror. Okay, and for this I will go to a different handpiece. I'm going to talk about that one in just a second, and I'll do it a slightly different way. The further back in the mouth we go, it becomes more and more difficult or less surfaces that we can cut with direct vision. But I'm saying anywhere between 50 and 75% of the surfaces that you cut, you should be cutting with 2 hands and direct vision. Let's move on to our next part, which is the speed increasing. So here's me just cutting again, 2 hands. And wherever it is, it can be that your other finger is on the side of the turbine, could be on the top. Sometimes at the back of the mouth, I've not got access to get a finger onto the turbine. I've got another finger on my finger, but still the fact I'm pressing against it will lock my wrist. So let's talk about speed increasing handpiece. Okay, this is a piece of kit which you have to have. Okay, end of story. You want to be a good prepper, you want to do good work for your patients, end of story, you have to get yourself a speed increasing handpiece. The speed increasing handpiece, this is the NSK one, which I use. The speed increasing handpiece is also referred to as the red stripe handpiece. Now, what's the speed increasing handpiece do, first of all? It can fit onto an electric motor or an air motor. Okay, it cuts with roughly 5 times the force, the torque of a turbine, but 5 times less RPM. So what does that mean? Another question to you. When you're prepping teeth, how many senses do you use? It may sound a strange question, but how many senses are you using when you're prepping teeth? You're going to say, obviously, sight, eyesight. And I've got loops on, so I've got really good eyesight. Okay, number 1. What else? You might say, I use smell. If I'm overcutting, not using enough water, I can see that the dentin may be burning, but also I may be able to use smell. Okay, not as easy nowadays if we've got all the masks, etc., that we needed to use for COVID. Third one, you're going to say, I use touch. Okay, really important. So let's look at touch. Our senses generally depend upon changes in the surroundings. So if we're in a darkened room, okay, one color of light, it's dark, we cannot see things. If we go into a room where somebody's been smoking, we can smell the smoke initially. 5 to 10 minutes later, you cannot smell the smoke. Why? Because there's been no change. So our senses are dealing with changes in things, okay? Let's look at pressure, okay? If I want to have really good tactile feel, then I need to be feeling changes in pressure. If I put my finger, okay, let's imagine I was doing this to somebody else, okay? I put my finger on somebody else's arm, like this. That person will feel me pressing in. I will feel pressure on my finger as I am pressing in. Now, what happens 5 minutes later if I'm pressing in with exactly the same force, and I've been doing this for 5 minutes? The person who I'm pressing into cannot feel it because there's no change in pressure, and myself, my finger can't feel it because there's no change in pressure on my finger. So our senses are dealing with changes. Now let's look at a turbine. Most of you will do your preparations with a turbine, which is fine, but there are certain drawbacks. With a turbine, okay, you cut at a high speed all the time, okay? And you cut at a constant pressure. What happens if you push harder on with a turbine? The turbine stops, it stalls. So we cut teeth with high RPM, but with the same constant pressure, which means that we have less tactile feedback coming through our senses, through our fingertips. So we don't know what we're cutting, okay? I cannot feel when I'm cutting with a turbine in an area where maybe I cannot see very well. I can't see how much I'm cutting off. That's one of the problems. Now, enter the speed increasing handpiece. What does the speed increasing handpiece do? Because you can push harder on it, or you can cut with lighter pressure, it now starts to give you more tactile feedback. It's a wonderful, wonderful instrument for cutting palatal surfaces. Okay, I just said the upper central incisor, mesial, distal, labial I've cut with the turbine. Palatal, I now cut with the speed increasing. Why? Because I've got less control. Okay, I've got to use one hand, in the other hand's my mirror. And when I'm cutting with water, that mirror will get splattered with water from time to time. So my vision's not as good. So I have to increase my tactile feel to get a better preparation. So in those areas where you cannot cut with direct vision, then I suggest that you cut with the speed increasing handpiece. Now, some dentists do all their work with the speed increasing handpiece. They use the electric motor, high torque, and they can cut everything. It's quite easy to cut old crowns off with the speed increasing using electric motor. Okay, whatever you do, if you're going to go and get one of these, make sure it also fits on, so it either goes on to electric motor or to air motor, but you have a foot pedal. Okay, you don't want to be dialing in the RPM. You want to be able to change the RPM with your foot pedal and also change the pressure with which you cut by pushing on harder or lighter. So I push on hard to start cutting a surface. Once I've cut that surface and I want to refine it, then I push on a lot more gently. I maybe change the burr again, go from a rough burr to a smoothing burr. Give you an instance. I find, I don't know about you, but I find one of the most difficult areas to prep in the mouth is, for me being right-handed, a lower right 6, could be 7, where I'm prepping, let's say it's a PFM, could be any restoration, where I've prepared the lingual, and I can get a good look at the lingual. I've prepared the distal, but getting the lingual margin and the distal margin to actually join up. Okay, it's difficult for me, for everybody, to get the tongue retracted out of the way, to get my mirror in so I can see what I'm doing, to get my handpiece in, also to get the angulation of the handpiece correct so I can cut with the right angle, and then to join those two margins up. It's almost impossible for me to do that with all those instruments in place. As we come further and forwards in the mouth, it becomes easier and easier because I've got better vision. But on a 6 or a 7, it's almost impossible. So guess what? I now go and do that joining up with the speed increasing handpiece. So I put my chamfer burr, let's just say it's a 0.5 millimeter margin. I put my 1 millimeter chamfer burr on the lingual aspect, okay, without the burr rotating, foot's not on the foot pedal. I now move it and I can feel where the distal margin is. I come back to the lingual, go to the distal, so I'm feeling my way. I'm not looking, I'm not using my eyes, I'm feeling my way tactile. And now I just start to put my foot on the foot pedal and go between the two. And I can feel the margin coming along. It doesn't suddenly just cut like that. The margin slowly starts to appear. And I've got great tactile feel. Wonderful for smoothing margins, wonderful for smoothing corners of preps as well. So for me, absolutely essential piece of kit. If I was doing a tooth prep today, tomorrow, and for whatever reason, my speed increasing handpiece went missing, sorry, cannot do it, cancel the patient, rebook the patient. Other things you should be aware of in these specific times, COVID-19, etc., is the aerosol generating procedures. It generates less aerosol than it does with a traditional turbine. So we are still generating aerosol, okay? I'm not saying we're not, but it is generating less than it would do with a normal turbine. And this is the work again from NSK that have been working on this. And you can see from the diagrams the sort of reduced aerosol. Next thing we're going to come on to, magnification, okay? And it goes without saying that if our target is bigger, we're going to be able to hit it much more easily. So please, guys, we need to get some loops. Loops for two reasons. Number one reason, you're going to be in this business for a long period of time. And listen to somebody like myself who's been prepping teeth, been doing dentistry for over 35 years now. I've had 2 discs removed from my neck, 2 discs removed from my lower back. I've had a hip replacement. Now, part of that is dentistry. Part of that is also that I used to play professional sport. I was a professional cricketer for 5 to 10 years, full-time or part-time. And so that has wear and tear on your joints. So professional cricket plus dentistry equals bad joints. Professional cricket and dentistry, and add in bad posture, sort of working like this with your head down, even worse. So magnification at least gets you the good posture, okay? And you want to be doing your preparation as though you are reading a paper, your head slightly bowed down, you're reading a paper. And that means that you need to get a good set of loops. The ones I use are Orascoptic, okay? I'm not saying they're the best on the market. There's many, many good ones on the market. They're the ones I happen to use. I'm not sponsored by them. And get a good set of loops where they measure the interpupillary distance. They also measure your own focal length so that you can get there and you feel comfortable with what you're prepping. I prep with 5.5 times magnification. I'd suggest if you're getting a new set for the first time, you go for something like 2.5 to 3 times. If you've already got 2.53, then trade up for 4, 5, or 5.5. Orascoptic have also got what they call eye zooms, where you can change the actual magnification on the lens. And what does this do? It just means that you see more. Okay, and imagine you're doing an anterior composite, and with the anterior composite, you've done your anterior composite, you've done the bonding, the finishing, and you can just see a slight blemish in it. Okay, now we put on the loops 5 times magnification. That blemish is this big. Okay, and we can take steps to get rid of that blemish because it's so big. So we work to the same standards. I've got loops on, I'm still working to the same standards. So I might see a blemish, which is tiny with my loops on. I take my loops off, there's no blemish there whatsoever. So it's so important, especially when you're doing margins, you're doing aesthetic dentistry, that you get yourself a really good set of loops. Lab techniques. We need to understand lab techniques. As I mentioned already, we have a partner. Okay, I might be the best prepper in the world, #1, gold medal at the Olympics. okay? But my work will be no better, no worse than anybody else's because of my technician. So we would need a world-class technician to work with us. If we don't have a world-class technician, we need to have an excellent technician. If it's not excellent, we need to have a very good one. If not very good, a good one. We cannot have a poor technician with us, because whatever you do then is going to fail by the technical aspect. So whether you like it or not, guys, we're in a partnership. If it's a true partnership, I should understand what he does. He should understand what I do. Okay, so it's really, really important that we start to understand lab techniques. With a PFM, for instance, we've got probably about 10 or 15 decisions which your technician is going to make, which will alter the appearance, the fit, the function, the longevity, the aesthetics of your restoration. He can go and choose the wrong 10 decisions. He can choose the right 10 decisions. Okay, now technicians, remember, they are in business. They're in business. And why are they in business? Not just to support you. That would be great, wouldn't it? But they're not. They're in business to make money. So they will make money two ways: increasing their prices, and from time to time they do this, or decreasing their overheads. Let's look at the two biggest overheads which technicians have. Okay, those two are manpower. Okay, so if they can get more work done in a day by changing a technique, so my technician now can get 10 crowns out during a day rather than 7, okay, that will improve the overall finances of the practice. So manpower is one, and the other part is materials, okay? And if a technician can reduce the cost of materials, then he's making more money. So a lot of decisions that are based, that are coming to us in terms of restorative work and clinical work from the technician are not based on purely what is best for that patient and that particular crown, but they are based on finances. We have to understand that, okay? We live in a cynical world. Be cynical, please. So how can we influence that? We can say to him, please use the best materials. And whether he does or doesn't, we have no idea, because we don't know the techniques and materials. Hence, we have to start to understand, okay? How do you understand? Several ways. Number one, go visit your technician, okay? Spend some time with him, start to understand and question him, okay? Such as, you are pouring up a model. You've sent an impression, Laurite 6 PFM. Going to pour up the model, okay? What stone is he using? Is he using a cheap stone, a medium stone, or the best stone you can get on the market? Or is he doing something better than stone? Is he using silver dyes, which is even better than stone? Okay, then the question is, why are you using that material? Well, I'm using that material because it's relatively cheap. That's not a good answer. You want him to use the best stone material. Why? Because that margin of your preparation, if it's not the hardest stone, it will chip. Remember, if it's a chamfer, okay, just draw a chamfer. A chamfer, when it's drawn, has a sharp edge to it. If he's using a soft stone because it's cheap, that edge will just break off a little bit, okay? It'll chip. Margins chip. When margins chip, you get poor fitting restorations. So you want the best quality stone. What's the best quality? How do you know? You have to go and understand. You have to go and learn. This is part of your learning to tooth prep properly, is understanding what your partner does. Okay, and for me, I use a German stone called Daytona. Cafe D is very good. Fuji Rock is very good. But as I've mentioned to you before, I use silver dyes. So I will go and get my rubber-based impression silver plated and then poured up. So when the impression comes off, I have a silver margin. All of these lab techniques, as I've mentioned, 10 different questions and answers from each different technique he's going to be using. Is he going to use the best, or is he going to use the cheapest? How do you get to know these things? So number one, go and talk to him about these things. Number two, go on courses with him. So on courses where I'm attending for many, many years, I used to take one of my technicians along. So we'd look at a big picture on the screen and we'd say, how can we get there? How can we both improve to be able to get to that? Also, subscribe to a lab magazine. Okay, so get yourself, and Quintessence do a really great lab magazine. It's there sort of almost in between the technician and the dentist. And if we look worldwide, and all of you, you put down your top 10 cosmetic restorative dentist prosthodontists in the world. Okay, put them all down, list them all down. I bet most of those people have at some stage done their own lab work or have an intimate knowledge of lab work. Okay, I was very, very lucky that when I did my Eastman degree, I did my master's degree going back many, many years ago at the Eastman. Our normal standard day, I did a 2-year master's degree. Our normal standard day started with 9:30 seeing, doing a seminar. 9:30 till 1 o'clock, we had a seminar. 2 o'clock till 5 o'clock, we saw patients every day. And then from 5:30 till 9 o'clock, we're in the lab. Okay, at the Eastman, we had to do all our own lab work. Now, at the time, it was really, really pressurized. However, now you look back on it, that has given me the opportunity to understand intimately how we make things, how we pour models up, how we make restorations at the margins, how we wax things. So we had to do our own modeling, our own waxing, our own casting, putting on our own porcelain, and we had to do 50 units before we actually qualified. I can now talk to a technician on his level, okay? And all of you, you go and talk to your technician and you ask him a question, and he'll come back, oh, we can't do that because of A, B, C, and D. What do? You go, oh, yes, okay, fine, yeah, you're the boss, you know that, fine, won't ask again. You feel intimidated by the technician talking to you because you know, you should know this, but you don't know it. So what do? You go, yes, yeah, sure, oh yeah, I agree, yeah, that's fine, that's fine. Okay, that's not the way it should be working. We should be having eye-to-eye contact. And when I say, can you do this for me? Okay, and he comes back and says, we can't do it because of A, B, C, D, and E. You go, hold on. I've read that you can. I know now with the new milling that you can. I've done something similar to that, so I'm pretty sure you can. And what's he now do? Oh, well, you can do it. What I meant to say is we don't normally do it, but we can do it. And now you have a better mutual respect for each other, and you'll get better restorations done. So absolutely essential, guys, that you understand lab techniques. Let's just run through a few. Choosing the right ceramic. Okay, you and your technician need to work on which is going to be the right ceramic, whether it's going to be translucent, whether it's going to be opaque. Naturally going with that is shade taking. Okay, understand what your technician needs for shade taking. Okay, and this is a huge part of it. Let's look at the traditional shade guide. Our traditional shade guide is a Vita shade guide. Okay, look at it. What is it? It's made up purely of porcelain, purely of ceramic, and it is 4.2 millimeters thick. Okay, 4.2 millimeters thick, nearly half a centimeter thick. When are you ever going to do a preparation which is 4.2 millimeters thick? You're not. Okay, so you're going to do a preparation where you've got, technician has got maybe 0.7 to 1 millimeter of thickness of porcelain. Therefore, the porcelain that the technician should give you for a shade guide should match what he's capable of doing. Now, guys, let's go and say we're going to do upper right one, porcelain fused to metal, okay? And we bring out our Vita shade guide. Do you honestly think that that Vita shade guide with 4.2 millimeters of, let's say, A1 ceramic is going to be the same end result with 0.7 A1 ceramic on a white opaque background on a black oxide layer of metal? The answer is, of course, no. You should not. You should never use your Vita shade guide for doing PFMs. So what should you and your technician do? You should ask your technician for a new Vita shade guide. Okay, and that Vita shade guide is him actually making shade tabs. So this is now my technician making me a shade tab. Here's the standard Vita one. Here's my technician's shade tab. And this is using 0.7 to 1 millimeter, somewhere in between, of ceramic on a white opaque background on a black oxide layer of metal. So this is a porcelain fused to metal Vita shade guide. This is a all ceramic Vita shade guide, which you get from Vita. This you're going to have to get your technicians to make for you, and that's expensive. He's going to charge the same amount as he'd do for a crown. Okay, so I had every single one made with a new shade guide. So there's an awful lot of crowns there that I paid for. Alternatively, if you use a certain color, we all have certain colors, B1, BL1, A2, A1. So maybe you get 5 or 6 Vita PFM shade tabs made. Next thing is that we need to look at the nuances. As we get better and better, more aesthetic dentistry, we have to look at the nuances of shade taking. And we can't just go and say, PFM shade A2, please, where we want to go into aesthetic dentistry. So we need good shade mapping. And for this, you need something similar. This is what we use. We have used in the past. This is a Juicera Creative Color Wheel. Okay, now what does this do? First of all, you can see lots and lots of different colors around here. So it has 4 colors for incisal translucency. It has colors for dentine. It has colors for crack lines. So what we do is, let's just say I'm going to do a bridge. Whether it's PFM or zirconia, it doesn't matter. I'm going to do a bridge here, and I want it to look very natural. So I want exactly the same emergence color here, and I want to shade map that tooth exactly. Okay, well, let's go and look at the emergence color of it. What color is that? It doesn't match a Vita shade guide. Okay, what it is actually matching now, I'm looking, it's maybe somewhere between 12 Solaris or 13 Banana. All these are given really exotic names. But now, once we've got exactly the right color, we can do some shade mapping with a nice photograph and a diagram, and the technician can put exactly the right shade in the right position. I'm doing a couple of incisor crowns here. So all ceramic crowns on both of those lateral incisors. Okay, and what I'm trying to mimic now is little crack lines in them, and also the dentine color on the incisal edge. What dentine color? Do I put to my technician, please make dentine color? Dentine's all different sorts of color. So we go to our mapping, we go to our dentine colors, and we look at what's on the incisal edge of the dentine here and here, and we shade map it, and we say to our technician, put the same color in. We do the same thing from the white crack lines. And this way we can now build up a beautiful picture and break that shade map down into individual small sections. Stump shades are important. Okay, remember, for a translucent restoration, okay, doesn't matter for opaque, for translucent restorations, you also have to give your technician the stump shade as well as the final shade. And he needs to work out how he gets from that color, the stump shade, all the way to the final shade. Okay, and that then means he will choose a certain amount of opacious dentine. These are opacas. So these are opacious dentine powders, opacas which you'll put in. And remember, for an all ceramic restoration, the best looking restoration we'll ever get is a translucent one. And for that, we need the right color background. So we ask people, we teach dentists, bleach and bleach and bleach till the tooth's the right color, then do a minimum preparation on it. Sometimes you don't have the time. Sometimes we will be working on a darkened background. And my technician now needs to put the minimum amount of opacious dentine, maximum amount of translucency in there to get the beautiful natural looking tooth. And for that, we need to understand stump shades. We also need to make sure that we do the color mapping, just like we did previously here. We'll do the color mapping for a stump shade. Sometimes it's all one color and it's easy. Other times we might have, maybe with a root filled tooth, certain areas which are darker than others. Okay, and the technician now has to lay down a bit more opacious dentine in that area and a bit less in another. So absolutely essential we do shade mapping for the stump as well. Pink porcelain. Okay, we have pink porcelain shade guys. More and more of us nowadays are doing implant work, implant restorations, And most of the implant restorations you'll probably end up doing anteriorly will involve a little bit of tissue loss. We can therefore either do connective tissue grafting or surgery, or we can replace that tissue with ceramic. One of the ways of replacing with ceramic means that we have to understand different colors and again, different shade tabs. So I'm going to do a case here now. And what's really important to me, patient has a low lip line. So this part of the ceramic here is not going to be as important, but the part that's going to be important is the interdental papillae at the front matching with that interdental papillae there, because that's what's going to be on show. So here we are now. We've done our shade mapping, and I'm trying to map this color. I'm trying to map that color here, especially there. So it's a contralateral tooth here also. So that means detailed color mapping. Again, a pink porcelain, you look at all those different shade types. Let's just look back at this soft tissue. Look at all those different colors. Here, a little line there, different color, different textures. Okay, here, scarring. So all the gingiva has got lots of intimate different colors. And again, you need to therefore shade map the pink if you want a really nice result. And here we've got a good result. We've got that papillae, which looks pretty similar here, here, and there. End result, good. What comes hand in hand, and I think from my point of view, a good looking restoration doesn't just rely on color. Okay, if I'm looking, there's 4 aspects to get a good looking restoration. And color's not the most important. For me, the most important is shape. So the technician has to map the shape exactly. Okay, that's the most important. Second most important is texture. If he gets the texture wrong, they'll be too shiny or too dull, and the light will reflect off it in different ways. Third for me is color, and the final one is the polish, the amount of luster. So for me, we need texture and luster guides as well. And here we have different lusters, different shines, and here we have different textures. So we've got a rough texture, we've got a smooth texture. Let's just look at textures. So we've got 3 fruits in front of us. Avocado, go back one, sorry, avocado, orange, and tomato. So these are what our tooth surface looks like as we age. So we start off, we've got a very, very rough tooth. Okay, and this is the young person. And the young person needs lots of texture on the surface. So the light scatters everywhere. We go to middle-aged, and of course, toothbrush abrasion, acidic drinks, etc. We've got a lot more, a lot less texture. And we then go to older age, and our texture becomes even less, now into glass texture, glass-like texture. So we need to be able to give those textures to our technician through texture guides. Now, one of the best ways to look at texture and also to look at anatomy is by using silver dyes. I've mentioned to you earlier, take an impression for your master impression for your crown, send it to your technician, but ask him to silver plate it. Okay, lots of technicians use silver plating. If you have a problem, email me and I'll send you to a technician who can silver plate for you. And then you get silver plated dies. Now look at the silver plated dies here. Imagine I'm going to do 2 restorations. Okay, let's say I'm going to do an upper right central here. I want my upper right central to look exactly the same as my upper left central. What can I now see on my upper left central? Look at the light reflecting off the silver. I can see a bulge there. I can see that distal marginal ridge, the exact shape of it. I can see that instead of one central lobe, I've got 2 central lobes with a little line in between. If you go and look at a stone die will not show you that because the light does not reflect off it. Now let's look at here. I'm going to be doing an upper right central incisor again. This time, not only can I see the anatomy, look at that texture. Look at that beautiful texture, which I can see here, all the horizontal striations. And again, my technician now needs to put that texture into his restoration. This is how we go up a gear. By number 1, understanding how we prep teeth properly and doing a proper prep. Number 2, understanding lab techniques and working with a better technician or training up your technician. As I said, the other thing it gives you is beautiful margins. Margins which if you take a wax knife over the margin, For the next 2 or 3 years, you will not damage it. Stone margin. Take a wax knife over the margin the first time. Depending on the stone, it's damaged. Also need to understand how we work with diagnostic wax-ups, preparation guides, prototypes. With our preparation guides, those are usually either putty matrices or these clear suck-downs. I prefer the clear suck-downs, to tell you the truth, and I like to put lots of holes in them and use a perio probe to probe through, so I know the space that I've got there, and I know that I'm cutting the right amount of space for my technician. Making the prototypes, putting the prototypes on, and then, guys, very important, once we've got our prototypes on, working with the patient to make sure the prototypes are exactly correct, not roughly correct, but exactly correct, and then just copying those in the final restorations. So all I say to my technician is, please copy. Copy the shape exactly. And there are ways to copy shapes. You need to understand how we copy shapes. We can copy the palatal, the labial incisal by using putty matrices. We can also use custom-made incisal guidance table. Here's a Durolay custom-made incisal guidance table. If you don't understand the technique, you don't even know of the technique, never heard of it, then you won't be able to ask your technician to do this. But this is a functional way, not just a visual way, a functional way of copying the anterior guidance from prototypes into the final restorations. If we want to copy the incisal index or the incisal edge position, then we need an incisal index. So here's my patient now. We're going to do some veneer and crown work for this patient. So I've done my veneer preparations. I've put my prototypes on. My prototypes are looking good. I now need to copy. How do I copy? I take an impression of the prototypes in the mouth. Technician mounts that model against the lower model. He now on the lower model puts some putty, but he indents the teeth. He indents the teeth on my model of the prototype. So now we get little indentations in the putty where the incisal edges are of the prototypes. What's he do now? Take that prototype model off, put the model now of my preps in place, and on the model of the preps, he can see my prep. He can also see where the indentations are, and he can make the incisal edges go exactly into the indentations. Incisal edge matrix means that we can get exact copies of the restorations that we do. And our final smile. And the final part of preparing to prepare is the 12 o'clock position. Okay, important that we work at 12 o'clock whenever we possibly can. And the reason for that is nowadays we're dealing with aesthetics so much is horizontal lines and vertical lines. So the horizontal lines that we work to are interpupillary line or intercommissure line. The vertical line that we work to is usually the center of the face, center of the upper lip. And aesthetics is all about getting the incisal edges parallel to the correct horizontal line and getting the center line of your restorations so it is parallel to or in the midline and vertical, and it's at 90 degrees to the correct horizontal line. For that, we need to orientate ourselves properly. And we can only see the correct horizontal and vertical lines if we're sitting exactly behind the patient. And what I want to do is I want to prepare the incisal edges. Let's just say I'm doing 6 anterior crowns, veneers. I want to prepare the incisal edges so that they are parallel to the horizontal line I'm working to. I want to prepare the inclination of the tooth, not take too much off one side, not enough of the other. I want the inclination of the tooth, the long axis that's bisecting the mesial and distal walls, to be either parallel or in the midline. So again, it's perpendicular to the incisal edge prep. All these things will help the technician get the correct incisal plane. We've probably all done it or seen it, where we've gone to fit some restorations and for whatever reason, there's an incline in the restorations. Okay, they're leaning down to one side. Instead of being in the long axis, there's like this. The incisal edges are coming down. There is no way in the mouth that we can correct that. I'm sorry. That is a complete and utter remake. And it's a complete and utter remake because the technician did not work to the correct horizontal and therefore vertical line. So we need to understand how we give these things to our technician. And the first way that we can do it is with the FACEBO. And we need to understand that if we give a FACEBO registration to our technician, then we need to orientate it so the top part of the FACEBO is now parallel to the interpupillary line. Okay? When technicians mount their models, understand that the FACEBO goes in place and it orientates itself so the top part of the FACEBO is orientated parallel to the top part of the articulator. So whatever horizontal orientation your FACEBO is at, okay, in relation to the teeth, that will come out in the articulator. Technicians tend to work to, unless they're told otherwise, they work to the top part of the articulator as their horizontal reference guide. So if your FACEBO is like this, then that means the horizontal part of the articulator is like that. The technician will make his restorations parallel to it, and you will have restorations that hang down to one side. So two ways of getting around that. Number one way is to orientate the FACEBO. So we push up one ear, pull down the other until the FACEBO is parallel to the interpupillary line, and then we lock it. The other way to do it is to get a stick bite. And with a stick bite, this is particularly useful at getting the intercommissure line. So do a simple silicone bite with silicone, squeeze a little bit more silicone into the front, onto the front teeth, and now put some form of horizontal into it. And we can orientate that horizontal. It could be a lollipop stick, could be an Acidex brush, it could be a pencil. We put that in and we can orientate it so it passes through the intercommissure corners of the mouth. So we've got now the intercommissure line. And remember that if we have interpupillary line and intercommissure line not parallel to each other, we have to choose one. And the one we choose is always the closest anatomical landmark, which is, of course, the intercommissure line. So guys, that brings us to the end of my webinar this morning. I'm quite happy to answer some questions. So as I'm summing up, if you want to just type any questions down, I can go to that. Otherwise, from questions point of view, by all means, email me, drpaultipson@gmail.com, and I can answer any of your questions. Please be aware that we are doing lots and lots of these webinars free of charge through Tipton Training. So I hope that you've already signed up at Tipton Training, www.tiptontraining.co.uk. We run many courses, hands-on courses, and for those of you that have found this interesting, then we do phantom head courses, we do aesthetics courses, which are hands-on, where we teach you this sort of thing. We teach you how to prepare properly. We sit behind you, and it's one thing knowing the theory, it's a second thing putting it into action. So please go and look at the website. We have phantom head courses starting throughout the year. Obviously, we've been closed down for a period of time with COVID, but we're starting our courses again. Our phantom head courses are starting up in September, October time. So if you want to really learn properly how to be a good prepper, how to prep all of these things properly, improve your restorative dentistry, then please come along and have a look at our website and talk to us about the phantom head course. Do hope you've enjoyed it. And there is lots more to come. As I've mentioned, this is the starting point, if you like, for tooth preparation. I'm going to be doing another webinar a little bit later on in the month on the 4 elements of tooth preparation, where we go into occlusal incisal reduction, axis reduction, margins, resistance retention form, and then going to go and expand it even more. So we talk about those 4 elements in much more detail. I've already done one on margins. We're going to be doing another hour webinar on axial preparation, an hour webinar on occlusal incisal preparation, and an hour webinar on resistance retention form. So there's lots more to come. So keep an eye out from the website. Okay, so I'm going to go on to the Q&A. So thank you very, very much. Those of you that aren't staying, fine. Those of you that are staying, let's go on to our Q&A. Okay, so first question is from Sahel. When checking shade, which part of the tooth is used for the reference? Is it the incisal, middle, or gingival? Ideally, Sahel, we should be using all those parts. So we should do a shade map. So we're going to do the upper right central incisor. Okay, draw an upper right central incisor, a big one, and then start to shade map it. Okay, so usually with a central incisor, we'll use the other contralateral central. So if possible, use the contralateral tooth to do your shade mapping. And then when we're doing stump shade, exactly the same thing. Draw yourself a great big picture of your stump, the preparation itself. And again, do some detailed shade mapping. And really important as well is put one of your shade tabs, or all of them if you're using multiple colors, next to the tooth you're doing, and take a photo. And when you're putting it next to the tooth, do not put it on further forwards. It has to be into the correct labial palatal positioning. So always put it on the incisal edge of your tooth preparation. Hope that answers your question. Katerina, if the eyes are not aligned, which reference point do we use for the face bow? So if eyes are not aligned, we've got two options. Number one option is we do a traditional face bow, and where the top part of the face bow is maybe like this. But we have to give a stick bite to the technician. And that stick bite is usually giving him the intercommissure line. Now the stick bite is pretty useful because it's a bite. He can put it onto the upper model, he can put it onto the lower model. So he can always see the horizontal orientation. So even when he's doing this, the top part of the articulator may be there, but his orientation from the stick bite is here. So he's now trying to make the incisal edges all parallel to that horizontal orientation. Next one, Tarek, I'm confused about the burrs and their sizes. Oh, I'm sorry, Tarek. I tried to discuss it. I'll go through it one more time for you. Burrs come in all different shapes and sizes. To cut with precision, we have to use the correct burr. The correct burr has got the correct inclination, the correct cutting tip. I always use for my preparations tapered burrs. I don't use parallel sided burrs because tapered burrs have got an angulation, and I can now start to understand the angulation and start to go back to your geometry. Get yourself a protractor, get yourself digital calipers, and start now to orientate yourself and understand the size of your burrs. As I mentioned, if you are cutting a shoulder, you want the shoulder to be 1 millimeter deep, then you pick a shoulder burr, okay, flat-ended shoulder burr that is 1 millimeter thick. If you're looking to cut a chamfer, which is 1 millimeter thick, then you have to cut a chamfer with half the width of the burr. So you pick a 2 millimeter chamfer burr to give you the correct 1 millimeter chamfer, okay? If you happen to use a 1 millimeter chamfer burr to try to cut you a 1 millimeter chamfer, what happens is you get that lip. The whole burr cuts in, and because it's rounded, you get a lip, which is no good. So that's the basics again of size. Now the one with width, with angulation is get yourself a tapered burr, measure the angulation. Once you've measured it, then you can start to orientate the burr in space so that one side of the cut will give you the correct angulation. Most, not all, most of your tapered burrs have a 6-degree taper, which means a 6-degree convergence, which means therefore if you cut with the burr totally vertical, okay, as you're going through the mesial, the burr is vertical, you're going through the distal, the burr is vertical, you will cut with a 3-degree inclination, and that will give you a 6-degree convergence. If, however, you take that burr and you lean it to one side, so one side is vertical, the other side isn't, it's angled, you've now doubled the axial inclination. And we can now cut with a 6-degree axial inclination, one side, 6-degree the other. Gives us the 12-degree convergence that we want. I hope that's helped you again. Farhad, what do you use for polishing your veneers? Okay, I don't know if you mean polishing veneer preps or polishing veneers, so I'll talk about both. Polishing veneers, first of all, we start out with, at the margin, we start out with tungsten carbide fluted burrs. We go on to red stripe diamonds, yellow stripe diamonds, greenies, brownies, white stones, brownies, greenies, and then diamond polishing paste. If we're talking about veneer preparations, then I polish usually with a white stone, soft lead sticks, something like that. If it's a cemented restoration, I leave my axial walls rough, very important. If it's a adhesive restoration, I leave my axial walls as smooth as possible. Brindusa, thank you very much. Thank you, Brindusa. Nicola, that was excellent. Thank you. Thank you, Nicola. Fatima, the convergence angle will be established all around the tooth, right? Yes, not just mesial and distal, no. But remember that our labial surface is convex. Our palatal surface is concave. So our convergence angle matters everywhere, but matters more mesial to distal, because our mesial and distal walls are flat. That's what's going to give us our resistance retention form. We'll only gain resistance retention form labial and palatal on the gingival third of the prep. The rest of it is round, and we're not going to get resistance retention form from that. So it's the whole surface mesially and distally, the gingival third, buccally and palatally, that will give you your resistance retention form, and that's where our convergence angle needs to be exactly right. Precision dentistry. Mutaz, are we going to be provided with attending certificates? No, you're not. Isha, will you provide a certificate for this? No, I'm not. Fatima, great presentation, sir. Do you usually take both face bow and intercommissural line? I usually take just one. If I'm doing a face bow and I'm making my restorations parallel to the eyes, because my intercommissural line is parallel to the eyes, then I only need to use the face bow. And very often I'll just orientate the face bow slightly. If, however, I've got a really bad cant and my face bow is really disorientated, I'll take a traditional disorientated face bow and I'll then give a stick bite. So usually for most people, just a face bow and sometimes a little bit of movement to the face bow so it's parallel to the eyes. If I've got a lot of distortion, then I'll use a stick bite. Zahid, how to make sure that my preparation for bridge have the same path of insertion during the preparation stage? Bridges, Zahid, I have done a 4-hour webinar, 2 2-hour webinars on bridges and bridge preparations. You need to go and catch that. So with bridge design, the first thing is try and make it fixed movable, not fixed fixed. Fixed movables work at the back of the mouth far more often and have less complications than fixed fixed. And with fixed movables, you have 2 different paths of insertion. So with fixed movables, you don't have to get both preps parallel to each other. Only with fixed you have to do that. So try to limit the number. If you are doing fixed, how do you get your preps parallel to each other? Difficult, okay? You're struggling. Most people cannot do one preparation properly, okay? And I do all the phantom head courses around the world. I've done these phantom head courses and everybody's the same. They're not taught well enough how to prepare teeth. They're not taught to measure burrs. They're not taught to find the angles, to do two-handed preparations, to use speed increasing hand pieces, etc. So the standard of tooth preparation generally leads a lot to be desired, and everybody, not saying everybody, don't mean that, most people can improve their preparations tremendously by understanding what they're trying to do. So number one, I would say, understand your tooth preparations as single crowns. Get it so you understand everything that I'm talking about and you're doing it, and then you go on to bridges. But you cannot take poor preparation from a single crown and then expect to do good preparation on bridges. However, there are certain things. So if I'm doing a bridge in the lower jaw here, I want to make sure that my mesial of, let's say, a 3 to a 7. Mesial of the 3, mesial of the 7 are parallel. Distal of the 3, distal of the 7, parallel. Long axis of the 3, long axis of the 7, parallel. That's what I'm aiming for. And for that, you've got things that you can use. You can use preparation guides. You can use mirrors that have got lines on them, all sorts of things. Too big a subject to discuss just in a Q&A, I'm afraid, Zahid. Katrina, When you copy the incisal edge position, how does the index fit in the same way in the mouth and in the stone model fits in? Okay, so the index does not go in the mouth. Okay, so I take an impression of the prototypes in the mouth. Technician now mounts that model of the prototypes against the lower model. He now makes up that putty, puts the putty onto the lower model and pushes it onto the incisal edges of the stone model of my prototypes. Now, when I take the stone model off of my prototypes and I put the model of my preps, he can see where my preps are. He can also see the indentations of where the prototypes made into the putty or the wax. So those indentations are exactly the correct indentations in terms of shape, labiopalatal positioning, mesiodistal positioning. So all he does now is fabricate his porcelain into those incisal index, into that putty. Okay, so this way you can copy exactly, but it doesn't go in the mouth. Andy, thanks for your time and lecture. Could you explain the 12 o'clock position again? I missed that part. Okay, Andy. I want to sit exactly behind the patient at 12 o'clock. You look at an awful lot of magazines. Okay, let's look, I won't name names, but magazines, brochures that are trying to sell you new equipment, okay, a chair. And you see often the dentist sitting at 9 o'clock, the nurse sitting at 3 o'clock, looking lovingly into each other's eyes. You can't cut a prep at that angle. You can maybe get rid of some caries. So in order nowadays to understand aesthetics, as I mentioned, aesthetics is all about horizontal lines and vertical lines. So in order to see those on a patient, I can't see them if I'm sitting at 11 o'clock. I can't see what the horizontal and vertical lines are. I can only see them when I'm orientated exactly behind my patient, sitting at the 12 o'clock position. If I can now see them, I can prep my teeth so that they are either parallel to the interpupillary line or at 90 degrees to that interpupillary line. So it allows me to orientate my tooth preparations better in the vertical and horizontal lines. Katrina, do you have water in the speed increasing handpiece? Yes, it does. Okay, so please get a speed increasing handpiece where you can get water coming through. If you can't get water coming through, then it means that you have to cut very lightly, intermittently. If you get water cutting through, then you can cut more heavily and constantly. So it offers you another opportunity to cut. But yes, you should. Farhad, do you stop your margins to the contact point or extend and break the contacts? Farhad, I presume you're talking about veneers now. Obviously, with crowns, we go through contacts. With veneers, we do, and again, sorry to repeat myself, but I did a 3-hour webinar on veneer preparation not too long ago. Again, it's too big a topic to go and say in a one-word answer. The one-word answer is it depends. It depends on many factors. So many times I'll break through. I may break through one side, but not break through the other side. So I may do one where it's a slice preparation and one where it's conventional. Very briefly, we have more tendency to do slice preparations when we're dealing with diastemas, imbrication, removing teeth labially, palatally, mesially, distally. We have a missing interdental papilla. We have interproximal restorations. More likely to do a conventional when we have none of those problems. Amos, thank you very much, sir. Thank you for listening, Amos. Somya, so much information, sir. Thank you so much. Thank you very much indeed. Sahel, in continuation with my previous question, when you say hold the guide around the incisal edge, the teeth of the teeth, does it mean hold on the guide as parallel to the tooth adjacent to the prep? Okay, so first of all, guide. I'm not so sure what you're talking about, Sahel, when you say hold the guide around the incisal edges. Do you mean lab work or do you mean when I'm prepping teeth? Okay, if I'm prepping teeth, I have a tooth preparation guide which goes onto the teeth and I can now probe through it. So I don't use it there all the time. I take it on and off So I do some preparation, put the guide on. That can be a putty matrix, or it can be this see-through one. And I probe through the see-through matrix to see how much space I've got between my tooth prep and the internal aspect of my preparation guide. If it's the incisal edge index or guide you're talking about, then that goes onto the models. I think I explained that a few minutes ago. Please come back to me if you've got any more about that. Naseem, thank you, sir. Thank you very much, Naseem. Brindusa, I have a patient from UK, Paul, and I did him a zirconia bridge, but broken now. Yes, Brindusa, bridge work is not ideal in zirconia. Okay, PFM is your traditional material for bridge work. And one of the reasons why zirconia breaks more often is the bond, first of all, of feldspathic porcelain to zirconia is not as good. So it's more likely to chip. And secondly, the connectors that you need, because zirconia is just not generally as strong as PFM. The connectors that you need for zirconia interproximally, let's say between, let's just say you're doing replacing an upper central incisor and you're using the other central and the lateral. The connector between the pontic and the central, pontic and lateral, needs to be really long, sometimes in the region of 4 to 5 millimeters. And that means that it then interferes with the interdental papilla. So what a lot of technicians do is shorten the contact. Okay, so either way, if you have it interfering with the interdental papilla, then the aesthetics and the function, the cleansing will be down, won't be as good. If he shortens it, then the strength will not be good. So zirconia bridge work, I only do, okay, unless I'm really pushed. And I then say to my patient, this is experimental. If it fails, you have to go back to PFM and you're going to pay again for it. So the only ones I would normally do and be happy to do would be an anterior bridge where the forces are less, but also where I've got a reasonable amount of recession. And my patient's got, you know, high, maybe a low lip line or high lip, doesn't matter, but we've got recession. So my contact areas, contact points between them, the connectors can be long. That's the only time. Okay, next one, Andy again. How can the contour and profile of the prototypes be copied exactly onto the final restoration? By intraoral photos? No, absolutely not. We send an impression of the prototypes. Okay? So it's simple. We get the prototypes so they're right. We then take an impression of them, and that impression ideally is not alginate. That impression is usually a putty and wash, and we send that to the technician. He casts the model. He's now got the prototypes in front of him. So he can go and scan if he wants, or he can go and take, again, putty matrices and make his tooth, his new crown, so it fits into the putty matrix. Okay, and that can be incisal edge putty matrices. It can be a labial putty matrix. Palatally, you can do them as well, or you can copy it via custom-made incisal guidance tables. So there's lots and lots of ways of doing that, Andy. Okay, next one. Okay, Sahel, you mean shade guide. Okay, sorry, fella. Shade guide, put it on the incisal edge. Put it so it's in the right dimension this way, and put it onto the incisal edge. Just go back to your other question, Sahel, so I can see it and understand it a bit more now. Okay, in continuation with previous question, when you say hold the guide around the incisal edge of the teeth, does it mean the tooth on the guide is parallel to the tooth adjacent? No. So our tooth, let's say upper central incisor, okay, I'm now going to go and turn the shade guide so it's upside down, so the incisal edge of my central incisor shade guide is touching the incisal edge of my central incisor. Does that make sense? So you don't put it the correct orientation where incisal edges are next to each other. You put it opposing the incisal edge. So the incisal edge of tooth, incisal edge of shade guide are like this. I hope that makes some sense to you, Sahel. Okay, let's go down. Okay, Vishaka, thank you so much, sir. Sir, it's amazing. My pleasure. I hope you enjoyed it. Plenty more. Brindusa is posterior. Okay, it's posterior bridge. Okay, Bendusa, do them in PFM. I would not do a posterior zirconia bridge unless my patient is aware it may fracture and it's experimental, and I will then go and have to do it again in PFM and they pay for it again. So I'll only ever feel comfortable with anterior zirconia bridges where I've got recession. I can have long connectors. How can we access previous webinars? You have to go onto the website, Farhad, and you should be able to access them there. If not, please go to an email, www.louiser@tiptontraining.co.uk. I'll say that again, www.louiser@tiptontraining.co.uk. Bendusa, so what material? PFM Bendusa, PFM. That's it. Okay, guys, that's all the questions. 30 questions done. Thank you very much. Hope you've enjoyed it. See you again sometime soon. Look out for the next webinars, and I hope you've enjoyed it. Take care and have a very good day.